Hi, you guys. This is Shanna, and I decided to create a presentation on borderline personality disorder. I feel like it's one of the more underrated diagnoses in the DSM-5, and I feel like a lot of people don't know about it. And for how common it is, I think more people should know about it and be aware of what it is. So, the definition in short of borderline personality is that it is a mental illness marked by an ongoing pattern of varying moods, self-image, and behavior. A lot of people you see in the public eye and celebrities have the disorder. For example, Pete Davidson, he's been speaking out more recently about it, and Lindsay Lohan is suspected of having it, which, when you think about these two people and you look at this definition, it definitely can make sense. Lindsay Lohan with her history of getting into trouble with the law, doing very impulsive things, inappropriate behavior a lot of the times, moods go all over the place. Pete Davidson, he jumps into relationships really quickly, head first. It's just borderline personality disorder is a disorder where the person can see in black or white. It's always one extreme or the other. There's no in between or moderation in any sense. It's always just going full throttle. So I just wanted to put this chart out there because borderline personality disorder is part of a list of personality disorders, and they're all classified by cluster A, cluster B, or cluster C disorders. If you look at cluster A, that's like your paranoid, schizoid, typal disorders. So you're kind of paranoid, you're suspicious of others, you have different thought patterns because of your paranoia and suspicion and all that. Cluster B is the impulsive cluster. This definitely does fit with borderline. You have histrionic, narcissistic, antisocial in the same classification as borderline. Overly emotional and dramatic, self-involved, deceitful, manipulative, moody, fears abandonment, self-mutilation. And then cluster C is the anxious cluster, the avoidant, the dependent, the obsessive. Interpersonally, they're very sensitive. They don't want to be alone. They're very attached to the people they're around, and they're dependent on the people they're around. And they're obsessed with the little details, and they have a difficult time trying to figure that out and relaxing. So when someone has borderline personality disorder, just like the other disorders we went over in this class, there's a history behind that. And usually, but it's not proven, it is because the person has experienced early adversity in their lifetime, or they grew up or they had been in a dangerous or toxic environment for a while, and borderline personality disorder is a result of them developing coping mechanisms to handle these stressful situations. Now, what we see in, I'm just going to call it BPD from now on, what we see with BPD is that they do develop these coping mechanisms. Are they necessarily healthy? No, but they do this to deal with the stressful situation. However, they carry these ineffective coping mechanisms into non-stressful situations like just everyday life. And that's when you see these behaviors become, irrational. They become impulsive. They're manipulative. This is what they learn to do to deal with all the trauma and stuff they'd been through, and they don't know how to turn it off. So there are 9 main symptoms of this disorder. This is what these people are experiencing. They are experiencing fear of abandonment. They are involved in a lot of unstable relationships. They fall head over heels really fast. They might be the type of person you might see run off with someone and get eloped, or run off and get matching tattoos with a stranger that they're in love with, that kind of thing. They have an unclear self-image, so they're not too confident in who they are, so that's why they're more willing to kind of indulge in these impulsive behaviors. That's why they're more willing to run off and do these things. They're still searching for that identity, which they never really developed. They are impulsive, and they can experience self-destructive behaviors. They have a history of self-mutilation, suicidal ideation, suicide attempts. They don't always think through. That's the definition of impulsivity, but they don't think through the consequences of what could happen when they do these things. They just think in the moment, and they want to go, go, go. And that in itself, that impulsivity, can lead to self-destructive behaviors. These people have a lot more risk for health disorders and having issues with their diagnosis and stuff like that, because they're impulsive. They don't always think through these things, so they might not adhere to their medication regimen. They may not have the patience to keep with therapies. They might end up in the hospital a lot with something wrong with them, because they're out here doing these things. They're running themselves down too, especially if they're in that impulsive, that running mode, where they're just going different places. Comparatively, I would call it kind of like mania, but it's not the same as bipolar disorder, so don't get that confused. So the 5th one is self-harm, like I stated. 6 is extreme emotional swings. So they can go from pleasant. You could be talking to these clients, and they can go from being a pleasant client, talking to you respectfully. Oh, yes, I understand. They'll be cooperative, and then literally in a blink of an eye, they will be saying, "You don't want what's best for me. You're not trying to help me. You're against me. You're against me. I don't trust this." And they get upset just out of nowhere. 7, feelings of emptiness. They might not, feel fulfilled. That could be part of the reason they indulge in such risky behaviors and stuff, because they're trying to find themselves. They're trying to find something to fill that void. 8, explosive anger. That kind of goes with the emotional lability. Out of nowhere, they can just have these mood swings, and anger is one of them. And one thing I suggest as a helper, a developing helper, when we are working with these clients, they need their space. You don't know what may happen. They might have an episode of this explosive anger. You need to keep your space. You need to not sit directly in front of them. They need to feel like they have an escape route, kind of, if they need to get up and leave, and you don't need to get in their way, because it could be dangerous. And then 9, suspicion and dissociation. I kind of touched on this earlier. They get suspicious of your motives. Like I said, well, I don't think you want what's best for me. You're working against me. Dissociation, because they can kind of lose track of reality a little bit and say these ridiculous things, because again, they're thinking kind of about themselves a little bit in that sense. This isn't narcissistic personality disorder, but they can have a little bit of narcissism mixed in there. Now, the important thing to remember about BPD, and personality disorders in general, usually these people don't realize that they have these disorders without someone helping them, pointing out their behaviors and things like that. You have someone with depression or anxiety, they realize they have depression, anxiety, and they don't like it. They understand that it negatively influences their lives. They don't like having it, but BPD is just something that these clients think is a part of them. That's just who they are. And it very well could be part of their personality. And we'll get into that later. So I just wanted to make this slide to reiterate about how important it is to be aware of these clients' risk for self-harm and suicide. You really need to check up and get updates with that, because every time you see them, because they very well could change their mind in a second, like we were talking about earlier. So you really need to check in. You need to ask, are you thinking of harming yourself or others? Do you have a plan? All those different types of things, and you need to assess their suicidality. So, difficulties with BPD, I kind of touched on this earlier. Usually these clients have other disorders as well, so the symptoms of these other disorders can kind of mask or overlap the symptoms of BPD. So, for example, you can have a patient with depression, anxiety, bipolar disorder. They share a lot of the same symptoms, so you might just write it off as, one of those three. But really, it's BPD as well. And that's the important thing, because when you're treating these patients, a lot of time the BPD is overlooked. And they might be misprescribed a medication or given the wrong type of treatment, therapy, what have it, because they're not expected to have BPD. So, with these clients, it is extremely important when you are communicating with them to just be straightforward with your speech. You need to speak literally, and you need to set clear guidelines before starting anything for appropriate behaviors and expectations. Those need to be laid out up front, and they need to withhold those expectations. And if they don't, you need to just say, you need to withhold these expectations we laid out. Because like I said earlier, they see things in black and white. So you need to kind of be in black and white too. These clients love to push boundaries, so you have to stay within those guidelines you set. No exceptions. So treatment for BPD can involve cognitive behavioral therapy, dialectical behavior therapy, which works with them to try to get out of that black and white thinking. And then medications are used as secondary treatment. There's no specific medication that is used to treat BPD, but the symptoms can be treated. Like, you can give them mood stabilizers, and you can give them antidepressants, anxiolytics, what have it, to treat the symptoms. So that's actually the end of my presentation. I hope you guys enjoyed it, and I hope you guys learn more about BPD.